Alright, hi guys, a very good evening to all of you and welcome to our today's YouTube session. Sorry for this short delay due to some technical errors that we were facing. I hope I'm clearly audible and visible to all of you now. There's a live chat option in which all the students, those who are live, can give a quick reply if everything is fine, if audio and video both are fine. You guys can give me a quick reply. All the students, those who are live, Dr. Zia and all the other students. Yeah, okay, great. So a quick reminder to all of you about the new offerings, new batches that are being launched on the platform. And if you're subscribing to any of these courses, you can use the code PHARMA10 to avail a 10% off in your overall subscription. Do remember, you can even utilize the same code for buying an iconic subscription where you can avail the benefits of the Unacademy and Prep Letter both. Currently, Unacademy is giving this offer that you can avail not only 10% but 20%. So this is for only few days that you can avail this benefit from July 17 to 22, and the code will be same, which is PHARMA10. PHARMA10 will give you a 20% off in these dates. This is one of the new batch, especially targeting INI CET students starting on July 21. I think today is the day. And every day there will be a 4-hour class in this batch. Pharmacology will be conducted in this in the end of August or September. These are the list of faculties who will be taking part in this batch course, all the 19 subjects. So all the top educators on the platform, they are coming together to bring the best for all of you guys. Comprehensive FMGE batch, it is going to start in July. I think it has already started. It will run from July till December. Another batch, NEET PG test and discussion. In this pharmacology, we have covered already in around 16 hours. So topic wise MCQ have been discussed here, like one day we discussed like general pharma, then we discussed autonomic nervous system, and likewise other systems also we have discussed. So make sure that you are going to avail this benefit by using the very simple code, which is PHARMA10, to avail 20% off right now. So these are the prices, original price, these are the offer price that you are going to see. After this short introduction, I think we are ready to start with new PYQ. So not only this, in upcoming days we will have some more YouTube session in which I will be discussing some of the other classes, some of the other PYQ MCQ, especially targeting FMG, and I'm sure all my students are aware that the topics of FMG is very commonly being repeated in NEET PG as well. And according to my experience, I have analyzed both the papers, I've seen, heard from the student on the basis of the feedback of the students. NEET PG was relatively much easier compared to the FMG paper. Okay, so this is only on the basis of the feedback that we have received. I have conducted NEET PG as well. If any one of you have any doubt that sir is telling whether sir is right or wrong, you can check out the NEET PG recall series I have conducted here on the YouTube itself. Okay, so let us see what all question examiner has framed for all of you guys, and what all points where students got confused. So I hope all of you guys are ready and we can start. So this is one of the question. A patient with glaucoma and also suffering from bronchial asthma. This is one of the PYQ of the AIMS. Repeated question in AIMS 2014-15 में multiple times it has been repeated. Same question has also been repeated in NEET PG, and now we saw this in the FMG as well. So a patient having glaucoma, also suffering from bronchial asthma, which of the following anti-glaucoma drug should be avoided? There are possibilities. All of you guys must have seen this question in any of the social media platform, right? But anyway, for all those who are live, go ahead and let me know the correct answer, whatever you think, and whatever we are going to discuss in this. Everything around the question is going to be important. Okay, so I'm sure all of you guys are already aware that pilocarpine is one of the M3 receptor agonists. This will be causing meiosis. There is no point of avoiding this particular drug. Some of you are actually replying timolol. Now why timolol? Some of the students are replying timolol. Any idea? I mean, any reasons for you to avoid timolol? Please go ahead. That's correct answer actually. Timolol should be avoided. Why? Because timolol is one of the non-selective beta blocker. Timolol is actually what? It's a non-selective beta blocker. It will be blocking beta 1, beta 2 both, and they can actually precipitate your bronchial asthma. It can precipitate actually your bronchial asthma. Can precipitate bronchial asthma. Okay. Betaxolol is one of the selective beta blocker, and this is the one that we are going to prefer. It is mainly preferred beta blocker in bronchial asthma patient for treatment of the open angle glaucoma. Okay. Apracnidine, brimonidine, these are the alpha 2 agonists. They can also be used. They are going to decrease the aqueous secretion, so they can be used in asthmatic patient as well. There's no problem about that. Okay, so timolol is the one. It has been repeated previously as well. Let's see the next one. So there's a 29-year-old lady who is a smoker on nicotine replacement therapy for de-addiction. She now requires alternative therapy for the same. Which of the following drug is going to be useful? Flumaginil, acamprosate, varenicline, naltrexone. Go ahead, please. Which one do you think is the correct answer? Maybe you must have seen all this question already, but definitely it will help you out in ruling out other option. What is flumaginil? It is one of the benzodiazepine receptor antagonist. So this will be benzodiazepine ka antidote. It's one of the antidote of the benzodiazepine poisoning. Antidote of the benzodiazepine poisoning. Take it. Most of you are actually marking varenicline. That's the correct answer. So they are actually nicotine. Whenever it will act on its nicotine receptor, they will be acting as a full agonist. Varenicline, it is having partial agonistic property, not full. It is having partial agonistic property at the NN receptor, and whenever they are going to bind at the receptor, they will be having low level agonistic or the partial agonistic activity. Okay. The binding can competitively inhibit the binding of the nicotine, therefore the full agonistic activity will not present. We have always discussed this, that in presence of partial agonist and full agonist, this partial agonist is going to act as an antagonist. I repeat, if there is a full agonist and partial agonist, this partial agonist will occupy the site and it will act as an antagonist. It will not allow the full agonist to act. Decreases the symptoms of the nicotine withdrawal, also blocks the dopaminergic stimulation, the one that was giving you pleasure or the reward associated with the smoking. So all these are the reason these terms that we are using here has been taken from Goodman-Gilman. Okay. So varenicline can be used. Apart from varenicline, you know there is alternative that we have one more drug. Which drug? An antidepressant drug. Antidepressant drug that we can also use is known as your bupropion. PO nahi, right? So they are the serotonin, dopamine reuptake inhibitor, plus they are also having nicotine receptor partial agonistic property. So नाम में है PO नहीं bupropion. ठीक है. So varenicline is the correct answer. Naltrexone or opioid receptor antagonist. ठीक है. Next one. A patient suffering from asthma comes to you in the hospital. All of the following drugs are used in acute exacerbation except. So we always see some pattern, like in this examination we saw I think around 4 or 5 questions on the basis of a patient presenting with the asthma. Out of them I think 3 or 4 were in pharma. Okay, go ahead please. Many congratulations Dr. Neeraj. So in this series we are starting from 22, we will go retrograde. So after this we will start to talk about some of the 2021 in the upcoming series, in the upcoming session. And then likewise I will also discuss some of the session of 2020 and 2019. So up to 2019 I will be doing around 5-6 paper I will be revising here. Go ahead, all of you. Comes to you in the hospital, all of the following drugs are used in acute exacerbation except nebulization by salbutamol, oxygen therapy, IV magnesium sulfate, leukotriene antagonist. Other students, any other answer that you have apart from option C? Now in the acute exacerbation, what are the leukotriene antagonists that we know? What are the leukotriene receptor antagonists that you know? What are the leukotriene antagonists that you know? That is your montelukast, zafirlukast and pranlukast. Do remember a point that in the acute exacerbation, since they are not available by the inhalational route, right, they are not preferred. Other agents, if it is non-responsive to your salbutamol steroid, including the magnesium sulfate, can be used. Okay? So do remember that IV magnesium sulfate, which most of you are actually marking, they can be used. ठीक है, ल्यूकोट्राइन एंटागोनिस्ट एक्यूट एक्सर्बेशन में इसका इफेक्ट नहीं है. हाउएवर इन ओपीडी बेस्ड पेशेंट इट कैन बी यूज्ड एज एन एड ऑन ड्रग. एग्जामिनर इज सिंपली आस्किंग ऑल ऑफ द फॉलोइंग ड्रग्स आर यूज्ड इन एक्यूट एक्सर्बेशन एक्सेप्ट. सिंपल एज दैट. ठीक है, साल्ब्यूटामॉल नेबुलाइजेशन से ऑक्सीजन थेरेपी, आईवी मैग्नीशियम सल्फेट can also be used in a non-responsive cases in emergency condition. Reference is Goodman-Gilman 13th edition. Patient with bladder cancer on chemotherapy drug who is also a known case of CKD developed tumor lysis syndrome and having very high level of serum uric acid. So we all know whenever there is lysis of the cell, uric acid level may be high. Which of the following drug provide fastest reduction? Now, in this particular option, multiple drugs can be used, but examiner is asking specifically which will be reducing fastest reduction of uric acid level. Go ahead, please. However, if there is any particular doubt with respect to this question or with respect to language that you guys are having, you can approach in any of the handles that we have. We are available on almost all the social media handle. You can just write it down, tag me, and as soon as I'll see, I'll reply to that. All of you please try. Fastest reduction of uric acid. Now many of you are marking other options B, C, allopurinol B, C is mannitol. Okay, mannitol कैसे uric acid को reduce करेगा? वो तो osmotic diuretic है. So is there any difference in the mechanism of action of these? Both are xanthine oxidase inhibitor. The correct answer according to Goodman and Gilman 13th edition that we have, fastest reduction is seen with the RAS uricase. Fastest reduction can be seen with the RAS uricase, that you should know. Okay, read, this is the textbook saying RAS uricase is a recombinant uricase. We all know this one. So where we have another drug like P-glotticase and RAS uricase. Alright, so they say it has shown to be lower the urate level more effectively than aripiprazole, more effectively, faster acting. Do remember, it is indicated for the initial management of the elevated plasma uric acid level in the pediatric and adult with the leukemia, lymphoma, or any of the solid tumor malignancies, those who are receiving any anti-cancer therapy. I have not made any changes in these languages. As it is given in the textbook. You can check it out. Can I use allopurinol? Yes. Can I use febuxostat? Yes. There is no contraindication to that. But when the question is telling more effective, fastest acting, terms like that, when it is used, definitely I'll be going, it is my personal recommendation, I'll be going through RAS uricase. Okay. It is going to increase the uric acid metabolism to a water soluble metabolite known as your allantoin. Allantoin will be causing fast, it is water soluble, faster excretion of the uric acid will be seen. 28-year-old female with the first trimester pregnancy comes to you in the hospital with a high level of T3 and T4. Which of the following drug is most appropriate to use? Carbimazole, propyl thiouracil. जो भी इंपॉर्टेंट पॉइंट्स है मैंने अंडरलाइन कर दिया. पोटेशियम आयोडाइड, propranolol. Go ahead please. Which one do you think is the correct answer? So this is a case of hyperthyroidism during pregnancy. Most of you are marking B. Okay. So hyperthyroidism in a pregnancy, whenever they are telling, so you will be giving anti-thyroid drug, no? You will be giving anti-thyroid drug. Like propranolol is having peripheral T4 to T3 conversion inhibitor, so anti-thyroid. Potassium iodide, they are going to inhibit the thyroid hormone secretion. They are the thyroid constipating agent, of course, anti-thyroid. Carbimazole also, propyl thiouracil. So all of them are anti-thyroid. Okay. Now, out of them in the first trimester, which one are you going to use? Yes. So if the patient is coming to you in the first trimester, we will be using propyl thiouracil, a drug that is having thyroid peroxidase inhibitor. Plus, it is also going to inhibit peripheral T4 to T3 conversion. That is an additional property. Apart from that, we have second to third trimester when the patient is coming, then we can use drug like your methimazole. Can you guys tell me if the methimazole is exposed in the first trimester, what will be the outcome? Methimazole या carbimazole, because carbimazole is a prodrug of methimazole only. If it is given in the first trimester, what will happen? What will it do? Teratogenic effect. बहुत प्यारा सा नाम है इसका. Aplasia cutis. There is a scalp defect. I have shown you this image in the regular classes as well. Scalp defect. ठीक है, कई बार हमने क्लास में डिस्कस किया है. Razak, I clear my FMGE. I had never done pharma because of fear, but last time I joined Siraj sir and done it. I will recommend all of you guys. Thank you. Many congratulations, Dr. Razak, and best wishes ahead. Okay, so they will be, if it is given in the first trimester, they are associated with aplasia cutis or the scalp defect. So we will not be giving the first trimester. Correct answer for this one is going to be propylthiouracil. Next one. 29-year female with history of hypercoagulative disorder. All right. Visiting OPD for anticoagulation treatment. So anticoagulants, we have mainly few anticoagulants like heparin, low molecular weight heparin, direct 10A inhibitor or warfarin. So which of the following should be avoided in the first trimester? I think ये इससे आसान कुछ नहीं होगा. If it was asked, इससे आसान कुछ नहीं होगा. Go ahead please. All of you guys are aware that warfarin is going to be correct answer, because in the first trimester, if it is given, it is going to be associated with a teratogenic effect known as fetal warfarin syndrome, also known as Contradi syndrome. Fetal warfarin syndrome, also known as Contradi syndrome. Alright. Other drugs like enoxaparin, they are the low molecular weight heparin, they can be used. Unfractionated heparin can also be used. Okay. So A and D are same only. Enoxaparin is a low molecular weight heparin only. Yeah. So if you remember, just prior to examination as well, and just in the recent general pharma class as well, we have covered. I have given a table in which I have discussed important 10 to 12 drugs and their teratogenic effect, their teratogenic outcomes. Okay, so regular classes में we have been discussing this very frequently. Although most of the questions are in the form of clinical, which we have been telling continuously in the class, yes, clinical based. Even the simplest of the question is going to be in the clinical form. If the examiner wanted, he could have asked this much: which of the following anticoagulants should be avoided in the first trimester of pregnancy? इतना काफी था, but still has been given 3 lines about a case. They are trying to give you a case, understand the case. Okay, a drug of choice for Legionnaires disease. Go ahead, please. All of you. You have to do a lot of question, so be a little quick. Erythromycin, azithromycin, vancomycin, tigecycline. Tigecycline is one of the congener of the minocycline only. Minocycline. The class under which it is, classified, उसका नाम होता है glycyl cycline. Tigecycline, it's same as one of the tetracyclines, having better pharmacokinetic property, of course. B, most of you are marking B, azithromycin. So in most of the atypical infection, guys, like atypical pneumonia, which is caused by mycoplasma, chlamydia, most of the other atypical pneumonia like Legionnaires pneumonia, ठीक है, और atypical mycobacterium infection, उसमें भी we can prefer the drug azithromycin. Do you remember, it's the drug from the macrolide group. It is having less or no drug interaction, longer T half life. ठीक है, they have longer T half life, so once daily can be given because of their prolonged post antibiotic effect. They also have less drug interaction, unlike other macrolides like erythromycin, clarithromycin, which is a very potent enzyme inhibitor. Azithromycin does not have any enzyme inhibiting capacity. ठीक है. A patient suffering from breast cancer is on chemotherapy taking multiple anti-cancer drugs. As cancer is not responding to the low dose therapy, there is a need to increase the dose of chemotherapeutic agents. Which of the following drug require monitoring of the bladder function? Okay, so which agent require monitoring of the bladder function? Which agent interfere with the function of the bladder or can cause some toxicity with the bladder? Go ahead on the higher doses. So these 4 lines, 5 lines in fact, and just this 2 lines. Which of the following anti-cancer drug require monitoring of bladder function? Even if you are going to read the last 2 lines, your work will be done. Gemcitabine, cisplatin, methotrexate, ifosfamide. Come on guys, this is something that we are expecting all of you should make correct, because all this question you must have seen somewhere or the other. आपको पता है, we have a drug by the name of cyclophosphamide, ifosfamide. They are actually metabolized. One of the metabolite is known as your acrolein. This acrolein is actually toxic to bladder. It can lead to condition like your hemorrhagic cystitis. It can lead to bladder fibrosis. It can also lead to, or it can also present with the hematuria. So painless hematuria के साथ भी patient आ सकता है आपके पास. So which anti-cancer drug can cause? Out of them, ifosfamide is having more risk compared to cyclophosphamide, but both of them can cause this. Acrolein is one of the metabolites that can cause hemorrhagic cystitis. So if the patient is going to receive drug like ifosfamide, we should keep an eye on your bladder. That's all. Gemcitabine, it is considered the drug of choice in a patient with the pancreatic cancer. Do you remember that they have the usual side effect? They have the usual side effect, and along with that they also have hemolytic uremic syndrome. Associated with the side effect, hemolytic uremic syndrome. Cisplatin, they are associated with some of the very, very important side effects. What are those? Like ototoxicity, nephrotoxicity, and maximum hematogenic. Most hematogenic anti-cancer drug is going to be cisplatin. It's a drug of choice in many cancer like head and neck, upper GI cancer, and genitourinary cancer. Methotrexate is associated with the renal toxicity, bone marrow suppression, hepatotoxicity, bone marrow suppression. It can also cause crystalluria. Like any other antimetabolite, it can even lead to crystalluria. So quickly we have seen some of the important points about other options. That is going to be one of the important one. Yes, very rightly mentioned by Dr. Mustafa, is in a patient who is receiving ifosfamide or cyclophosphamide, as a prevention we are supposed to add IV mesna. So prior to infusing cyclophosphamide or ifosfamide, give mesna. Okay, next one. Young male patient who is having family history of bipolar disorder. In his father has now come to OPD with symptoms of the mania. Okay, his genetic testing show positive for genes involved in the mania. Which of the following mood stabilizer can be given to him as the most effective drug for the mania? Which is the most effective drug? Isn't that you guys are aware about this? So even if you do not know the above 4 lines, if you know this much, which of the following is the most effective most effective agent for the management of the mania? You all know, right? Lithium. Lithium in fact is considered the drug of choice for mania. But can I use valproate? Yes. Can I use carbamazepine? Yes. We can use this. But drug of choice most effective is going to be lithium. More about lithium we have discussed a lot in our other sessions. Lithium is a very, very important drug. And in YouTube I have taken one of the session which is top 10 drug that you should not miss. Lithium is always my priority. Lithium, atropine, and the other drugs that I have discussed, top 10 drug which any student should not miss. Very frequently asked question. In fact, for prophylaxis as well, we are going to use lithium. Prophylaxis of the mania also we are going to use lithium. A patient of MI taking antiplatelet drug aspirin in a dose of 325. Which drug can be added to above treatment to enhance the antiplatelet activity? To enhance the antiplatelet activity, what will you add with the aspirin? I'm sure all of you have heard about the term that I am writing on the screen, DAPT. All of you guys have heard, right? DAPT. This is not new to any one of you. it is dual antiplatelet therapy, where we are going to use one of the COX-1 inhibitor like aspirin. Along with this, we will be using one of the P2Y12 inhibitor by the name of clopidogrel. So studies have shown that compared to aspirin alone, P2Y12 inhibitor addition increase the outcome, increase the benefit, right? Decrease the morbidity. So clopidogrel is the agent, not the anticoagulants like warfarin or heparin. It is the clopidogrel, and together we call them DAPT. What is DAPT? Dual antiplatelet therapy. DAPT is dual antiplatelet therapy. Okay, another quite similar question. Mechanism of action of aspirin in a patient suffering from thrombosis. So I just gave you the answer of this question. So on the same topic, two questions were asked. Fibrinolytics by converting plasminogen to plasmin. Okay, so think, which drug actually convert plasminogen to plasmin? I think it's pretty simple. Plasminogen to plasmin, and this agent, this plasmin is going to cause fibrinolysis. This is going to be a drug like streptokinase, urokinase, retiplase, tenecteplase, anistriptase, yeah. Inhibiting conversion of vitamin K dependent clotting factor to their active form. So this is going to be the mechanism of action of warfarin, and I just told you that COX-1 inhibitor. P2Y12 inhibitor are going to be drug like your clopidogrel, prasugrel. So this time they have asked this. Next time they can give you that whether they are reversible or irreversible. Do remember, these are the irreversible P2Y12 inhibitor. We have something known as your reversible P2Y12 inhibitor. Anyone can tell me? जो कैनुला से देंगे that is cangrelor. कैनुला से देने वाले agents are cangrelor, और टिक्का इज लाइक चिकन टिक्का ग्रिलोर जो ओरली ले सकते हैं. सो दिस इज IV एंड टिक्का ग्रिलोर इज गोइंग टू बी ओरल. टिक्का चिकन टिक्का या पनीर टिक्का, अगर आप वेजिटेरियन है तो पनीर टिक्का से काम चलाइए. तो टिक्का विल बी ओरल, कैनुला से कैंग्रिलॉर्स. दे आर द रिवर्सिबल वन. इट कैन बी यूज एटलीस्ट अप टू 24 आवर्स प्रायर टू द सर्जरी. ठीक है. सो दिस क्वेश्चन हैज बीन आस्क्ड इन द नीट PG एज वेल. नेक्स्ट वन, व्हाट इज द बेस्ट ट्रीटमेंट फॉर Raynaud's phenomena? Best drug that can be used for Raynaud's. So this time they have given some class, some drug like calcium channel blocker, beta blocker, nitroprusside and trazosine. Go ahead please. All of you please try. Even if you know this, even if you have answered, develop a habit of answering. A or C, some of you are marking A. Okay. So best treatment for Raynaud's, is it beta blocker? Is it nitroprusside? Is it trazosine? Is it CCB? Most of you are going ahead with A, and I will also go with the A. So most effective treatment is going to be A. There are many controversies about trazosine, but there are studies, those who are going against that, they are not very effective. But calcium channel blocker is the best agent. They are a highly effective drug. This is from Goodman and Gilman, 13th edition. Nifedipine, diltiazem, amlodipine, right, felodipine, they are peripheral vasodilating agent. Vasodilation will be caused by calcium channel blocker. Okay. Some study indicate that trazosine can decrease the incidence of digital vasospasm in patient Raynaud's. However, its relative efficacy as compared to calcium channel blocker is not known. So best one, if examiner is asking, we'll go ahead with the calcium channel blocker for the Raynaud's. There are chances that you must have got this question in form of a case, that a patient is washing clothes. ऐसे करके एक केस भी आ सकता है, हो सकता है आपको केस भी मिला हो. That patient is washing clothes and the hand color turns out to be bluish, है ना. Yeah, on exposure to cold, the turns out to be blue. Which of the following is the important and significant side effect of tamoxifen use? So go ahead for this one. I think this is a pretty simple one. Tamoxifen से क्या side effect होगा? Yes, resistant case के लिए we can use nitroprusside. Sodium nitroprusside can also be used in the resistant cases. I think this is also pretty simple, that we all know that tamoxifen is one of the selective estrogen receptor modulator. So they are also going to have agonistic activity at certain area. Like ER/PR of the breast, वो तो है selective estrogen receptor modulator. They are also having agonistic activity at pituitary, liver, uterus. So this is your answer going to be uterus. Also agonistic at the bone. So if it is agonistic at the bone, they are going to increase the blastic activity. See, if it can be increasing the blastic activity, it will be used in osteoporosis. It will not cause osteoporosis. Okay, examiner is asking side effect. So it will be used in osteoporosis actually. But if it is going to act at the uterine endometrium, it can cause endometrial hyperplasia. So this is one agent that can increase the risk of endometrial. If you endometrial carcinoma. If you want to avoid this, alternative that you can use is also raloxifene. Do remember, raloxifene is also having antagonistic activity at the endometrium. It is one of the second generation selective estrogen receptor modulator. It can safely be used. If there is a patient coming to you with the vaginal bleeding or dysfunctional uterine bleeding, है ना, उस तरह की symptom के साथ आती है elderly female, then we can prefer raloxifene. ठीक है? So this is the same thing that I told you have been mentioned here. A patient who has just recovered from COVID-19 infection visits your OPD with a black discoloration material in the nose and posterior part of the buccal cavity. He also gives the history of using high dose of steroids. So I'm sure all of you guys have seen, just after the second wave of COVID, black fungus वाला जो story चल रहा था. Although it's a layman term to use black fungus. During his treatment of COVID-19, which of the following is most suitable drug for this? So we are actually talking about a fungal infection known as your mucormycosis. For the mucormycosis, the drug of choice is going to be amphotericin B. Remember, azoles are ineffective in mucor. I repeat, azoles are ineffective except until we got posaconazole or we use even isavuconazole. Posaconazole or isavuconazole. In fact, posaconazole, it was the first azole which was shown to be effective in mucor. It was the first azole that was shown to be effective in a patient with the mucormycosis. Okay. Usually azoles were ineffective for mucor, remember. Okay. Drug of choice for them is going to be amphotericin B. A patient undergoing spinal surgery developed very high blood pressure, 240, 120. Which of the following drug is not used in the treatment of this patient? So what is not used? IV esmolol, IV nicardipine, IV nitroprusside, IV mannitol. So this is a case of actually hypertensive emergency. So which is not going to be used or does not have much of effect? Esmolol, nicardipine, nitroprusside, IV mannitol. Okay, so there are mixed responses, but most of you are actually going ahead with the D, IV mannitol. So what is IV mannitol, guys? It is one of the osmotic diuretic, no? Osmotic diuretic, mainly utilized if there is increase in the intracranial pressure or intraocular pressure. ठीक है? In a patient if there is cerebral edema. ठीक है? In a patient if there is a cerebral edema. Other agents can be used, and nicardipine being the drug of choice for hypertensive emergency. IV nicardipine, they have fastest onset of action. Okay, so what are the drugs used in hypertensive emergency? Nicardipine. Other drug that you can use, clevidipine, clonidipine, hydrazine, one of the potassium channel opener, labetalol, esmolol, they are the beta blocker, of course, can be used. Sodium nitroprusside can also be used, and phenol-dopam is one of the D1 agonist, they can also be used. Okay, they can also be used. But we are not going to prefer mannitol. Is an osmotic diuretic, mainly utilized in cerebral edema, okay, or dialysis disequilibrium syndrome. right? In this condition also we can use dialysis disequilibrium syndrome. A patient found roadside in unconscious state having pinpoint pupil. So look at the terms, very frequently repeated terms. Pinpoint pupil. Look at the heart rate, 54. Look at the blood pressure, 90/60. His history reveals a drug addict. Which of the following drug he must have consumed? Cocaine, morphine, amphetamine, haloperidol. Go ahead please. All of you please try. I think you all should know that cocaine is one of the agents that is having norepinephrine transporter inhibitor. Net inhibitor, they will increase the noradrenaline level, that will simply increase the blood pressure and heart rate. ठीक है, ये heart rate को बढ़ा देगा. ठीक है. Amphetamine is also a stimulant. ठीक है. Act by displacement reaction, so they will also increase the noradrenaline level. Haloperidol is one of the typical antipsychotics. They are D2 blockers. So the drug addict that we are talking about is going to be morphine. There in usual classes I used to give you a mnemonic known as POM. Have you heard about the term known as POM in my class? Pontine hemorrhage, organophosphate poisoning, morphine poisoning, phenol poisoning. Now these are the conditions. POM are the mnemonic in which patient can present to you with the pinpoint pupil. It's a differential diagnosis for the pinpoint pupil. Plus we all know that morphine on the high dose, they are having cardiac suppression property, cardiac depression property. Morphine on the high dose has a cardiac depression property, and if there is a withdrawal symptom, listen to me carefully, morphine ka, if there is a withdrawal symptom, the BP and heart rate both will be high. There will be mydriasis. I repeat, in a withdrawal symptom, the action is totally opposite to the actual effect that we see. Okay? So this is the same thing that I have already taught you. A person came to emergency with snake bite 8 hours ago. Okay? He already had been given 10 vials of antivenom at the local hospital. Following is the next step, if the patient does not recover and signs of neuroparalysis prevails. So let us say the patient has already received antivenom, and if the neuroparalysis signs are going to be same, we will be using, we all know that the toxin that we have, they are mainly going to act as a nicotinic receptor like NMK against. Okay? So neuroparalysis will be there. There will be flaccid paralysis of the muscle. There will be ptosis, diplopia, weakness. So we will try to give neostigmine as one of the reversible acetylcholinesterase inhibitor. And along with that, we also add atropine to mask the muscarinic side effect, because neostigmine can increase the acetylcholine level, and this acetylcholine can act on the nicotinic and muscarinic both. We want our action, boys and girls, only at the level of nicotine, not at the muscarine. So if you are going to give one of the reversible acetylcholine esterase inhibitor by the name of neostigmine, as I told you that neostigmine, it is going to increase the level of acetylcholine. And as we all know that acetylcholine will act on the nicotinic and muscarinic like M1, M2, M3. By acting on M1, it can increase the risk of peptic ulcer disease. It can cause some CNS action. By acting on M2, it will be causing bradycardia. By acting on M3, they can cause bronchoconstriction, excessive secretion. Right? So we want our action actually, because our NM is blocked, so we want our action at the level of nicotine, not at the level of muscarine. So we should try to inhibit these three. We should try to inhibit M1, M2 and M3, and non-selective muscarinic antagonist is going to be atropine. So to mask the muscarinic side effect, we add atropine, guys. Okay? That's the best thing that you can give to this patient right now. A patient with a long history of CHF, maintained ejection fraction and no signs of hypervolemia, okay, comes to you with the long QRS waves in ECG and cardiac wall hypertrophy. Okay, so hypertrophy, that means remodeling has started. Which of the following drug is best to be started to prolong the survival? So simply examiner is asking which drug can reduce the mortality. Which drug can reduce the mortality? So we know the drug that can reduce the mortality is beta blocker. We always start at the low dose beta blocker. Other drugs that can reduce the mortality are all the ACE inhibitor. These are the best or the most preferred agent. They are the best or most preferred agent: angiotensin receptor blocker or aldosterone receptor antagonist, like spironolactone, eplerenone. Okay? So they will be increasing the survival, plus the vasodilating agent that we have like nitrates, they can also prolong the survival. They will decrease the preload and afterload, therefore myocardial hypertrophy का जो risk था, that will be further reduced. So out of them, the most preferred is going to be, or the best that is going to be, is ACE inhibitor. The only ACE inhibitor in the option is going to be lisinopril. Out of the given choices, lisinopril is the only ACE inhibitors. Okay. A patient with hyperglycemia and positive ketone bodies in urine comes to you in hospital with altered sensorium. Right. So diabetic patient with the altered sensorium. Which of the following drug therapy is most suitable to start? Metformin, potassium chloride, insulin and IV fluid, ringer lactate. What will you start? This is possibly a case of ketone body भी आ रहा है, so this is possibly a case of diabetic ketoacidosis. So this is one of the hyperglycemic emergency, and we know because the sugar level is so high, your blood itself in the veins is so thick, it's like sugar syrup. So you have to increase lots and lots of fluid loading. You have to increase the fluid load, and along with that you will be giving insulin as well. In addition to insulin and IV fluid, we will also be correcting some electrolyte imbalances if there are there. Okay, if there is some electrolyte imbalances. Right, metformin is the drug of choice in diabetes. OPD based वाले patient को will be preferring this, but not in the emergency. ठीक है, so diabetic ketoacidosis, fluid, hypokalemia को correct करिए, IV insulin. ठीक है, rarely we can even need sodium bicarbonate. ठीक है, so it's an emergency. LD50 stands for, so we know what is ED50, we know what is LD50, and we also discussed therapeutic index is equal to LD50 by ED50. I need to give you the mnemonic, that is TILE, TILE, that therapeutic index is equal to LD by ED. Go ahead. 50% of animal mortality in an experiment after exposure to drug, 50% effect of the drug in animal sample, death of 50 animals in an experiment, 50% reduction of infection in the given population of animals. So we all know a dose that can kill the 50% of the experimental animal. I repeat, a dose that can cause mortality in 50% of the experimental animal will be an LD50. Remember, it's an experimental pharmacology का term that we are using. ठीक है, LD50, a dose that can kill 50%. ED50 क्या है? A dose that can produce therapeutic effect in 50%. ठीक है, a drug that can produce a therapeutic effect in the 50%. Therapeutic index. If the therapeutic index is narrow, that it will be an unsafe drug. Always remember. A tourist visited an Indian village and developed mild diarrhea. Okay. So the term that is used is mild diarrhea, which later on found to cause by E. coli. Which of the following is the most suitable drug of use in this patient? Go ahead, please, rapidly. Few more questions are left. Loperamide, rifaximin, octreotide, zinc. Which is the most effective, guys? Octreotide is mainly preferred in secretory kind of diarrhea. So this is one of the opioids, and we all know opioid decrease the intestinal motility. It will decrease the intestinal motility. So in this condition, like in a mild kind of diarrhea, we can even use loperamide as well. Right? This is actually traveling, visiting. So this is actually a case of traveler's diarrhea, as rightly pointed out by Dr. Soumyadeep. Traveler's diarrhea. Okay. Which of the following statement is incorrect? So out of 4 options, one statement is incorrect. You have to choose that. Carbamate bind to acetylcholine esterase irreversibly. So in the acetylcholine esterase, we have 2 sites. One is known as your anionic site, other is the esteric site, and carbamate will be binding to both of them irreversibly. Actually, it is going to bind to both the sites irreversibly. Okay, So that's true. Atropine is used in antidote of organophosphate. That is also true. You have to choose an incorrect. Proliferative has its role in reversal of enzyme in carbamate poisoning. You have to tell me this. Atropine is used in antidote of carbamate poisoning. So atropine can be used in both organophosphate, carbamate, both. Atropine will be a non-selective muscarinic antagonist, so it will reduce the symptom, cholinergic symptom को कम करेगा. Remember, because both the sites are blocked, oximes will not be effective. Why? Oximes usually binds at anionic site of acetylcholine esterase. Okay, it binds and then it will be forming a phosphodiester bond with the esteric site. Let's say if there is organophosphate poisoning, in that case they will dissociate. But in a patient with the carbamate poisoning, when both the sites are blocked, this is carbamate, if both the sites are blocked, oximes will not be effective because they do not have a place to bind. Okay? Oximes bind at the A site of the acetylcholine esterase in organophosphate poisoning. After binding there, they will form a phosphodiester bond with the organophosphate and dissociate. So we do not use oximes in organophosphate. Multiple time repeated question. A 70-year-old patient with the Parkinsonism suffers from constipation after taking anti-Parkinsonian treatment. Which of the following drug may be responsible for the above symptom? Levodopa, benztropine, pramipexole, metoclopramide. I want to hear this from all of you guys. Go ahead, please. All right. Levodopa, benztropine. Most of it marking D. Now, what is D? In a patient with a Parkinson disease, there is a degeneration of dopaminergic neuron. Yes or no? Degeneration of the dopaminergic neuron. Because of the degeneration of the dopaminergic neuron, we will try to supplement the dopamine because the balance is imbalanced, dopamine acetylcholine ka. So, for the management, either we try to give dopamine agonist or we try to give anticholinergic, mainly those who are having centrally acting anticholinergic property. Now some of you are marking D. See, metoclopramide, the D2 blocker है ना, it's an antipsychotic drug. It can be used as an antipsychotic, it can be used as a prokinetic. Metoclopramide is a D2 blocker. How can you use a D2 blocker in a Parkinsonium whereas already dopamine is lesser? Can you think, future doctor and Roshni, Ria, other student those who mark D? Metoclopramide तो strictly नहीं देंगे ना, D2 blocker तो बिल्कुल नहीं देंगे. Because of the degeneration of dopaminergic neuron, the dopamine level is already lesser. Dopamine level is already lesser. So for the management, we are going to give either dopamine agonist or centrally acting anticholinergic. अब बात करिए. C. Pramipexole. What is pramipexole ropinirole? Pramipexole ropinirole. Here we can use levodopa. Here we can use amantadine. Right? Here we can use, like, let's say pramipexole ropinirole. Now what is pramipexole ropinirole? First of all, they are also dopamine receptor agonist, non-ergot dopamine receptor agonist. They are non-ergot dopamine receptor agonist. Okay. Think about the other one, benztropine. Centrally acting anticholinergic में we have drugs like your benzhexol, benztropine. So don't you think that you should increase your boundaries a bit and think about some other option that could be possibly causing this constipation? Benzhexol, benztropine, trihexyphenidyl, procyclidine. Okay? So they are all anticholinergic agent, and we all know anticholinergic will be causing blurring of vision, dryness of mouth, constipation, don't you think? So your answer is going to be benztropine. You are going for obvious that yes, metoclopramide तो कहीं पढ़ा था, metoclopramide कोई side effect तो करता था, है ना? That was extrapyramidal symptom. ठीक है? That was a different question. but here I would choose benztropine. It's a centrally acting anticholinergic drug. Most of your mark B. Kudos to all of you. Next, drug combination which is preferred for MTP. Faster. Few more questions. Which is a drug that is preferred for a medical termination of pregnancy? Lubiprostone, mifepristone, mifepristone and misoprostol, lubiprostone and misoprostol, L-prostadil and misoprostol. Go ahead please. B. Mifepristone, Ru486 and misoprostol. That is correct actually. Okay. Where do we use lubiprostone guys? Anyone can tell me lubiprostone को कहाँ use करेंगे? Any student who can tell me lubiprostone का any use? It's a prostaglandin analog that will increase the chloride channel activity. So constipation dominant IBS में we can use. IBS में or any other case of constipation we can use. Okay. So for MTP we always use mifepristone and misoprostol. We all know that antiprogestin will be mifepristone with combination with the misoprostol or other prostaglandin we can use. Okay. So when mifepristone is used to produce the medical abortion, a prostaglandin is given 48 hours after the antiprogestin therapy. What is antiprogestin? Mifepristone. To further increase the myometrial contraction and ensure the expulsion of the detached blastocyst. Okay, misoprostol also causes cervical tightening. Remember that. The dosage is going to be 200 mg once orally. I remember in 2014 this question was asked on the basis of dose. You can check it out in FMGE solution. Dose दे करके पूछा था कि whether it's used 200 mg or 50 mg ऐसे करके और 200 microgram ऐसे करके पूछा था. So 200 mg orally. Then after 48 hours we can give misoprostol 800 microgram. Right, 200 microgram 4 tablets we can give vaginally we can give. Okay, for the medical termination of pregnancy in the first trimester, the most effective, most preferred one. In a patient with proliferative diabetic retinopathy, which of the following monoclonal antibody can be used? Go ahead please. In a proliferative diabetic retinopathy, which of the following can be used? Belimumab, bevacizumab, infliximab, rituximab. I think most of you will be marking this correctly. All of you guys are already aware that vascular endothelial growth factor inhibitor is going to be bevacizumab. Belimumab, what is belimumab? It inhibits the B cell activation. It inhibits the B cell activation. It can be used in a patient with the SLE. SLE में इनको आप use कर सकते हैं belimumab. Infliximab, we all know it's one of the TNF alpha inhibitor. Mnemonic is ICE and ARC like infliximab, certolizumab, etanercept, adalimumab, golimumab. Rituximab, the most commonly utilized monoclonal antibody. It is one of the anti-CD20 monoclonal antibody. It can be used in many conditions, but not in diabetic retinopathy. So in diabetic retinopathy, we'll be using VEGF inhibitor like bevacizumab, ranibizumab. Which of the following agent used in rheumatoid arthritis act by opioid and non-opioid receptors? Tramadol, paracetamol, etoricoxib, methotrexate. Opioid and non-opioid. A similar kind of question has been asked in the past in a in examination of NEET PG, and also more previously it has been asked in AIMS as well. But language को थोड़ा change किया था. इस बार language थोड़ा अलग है. All of you. A. What is tramadol, guys? It is one of the mu receptor agonist with SNRI, serotonin noradrenaline reuptake inhibitor. So it is acting on the opioid, so mu, and non-opioid receptor like serotonin noradrenaline reuptake inhibitor. Tramadol. Paracetamol, of course, it has no effect on the opioid receptor. It's a COX-3 inhibitor. Etoricoxib, it is coxib, so it's a selective COX-2 inhibitor. Methotrexate is one of the dihydrofolate reductase inhibitor. It is also not acting on any of the opioid receptor. Although most of the students have chosen methotrexate as a drug answer here, but do remember methotrexate is a drug of choice in rheumatoid arthritis, but it is not acting by opioid or non-opioid receptor. ठीक है, it's a dihydrofolate reductase inhibitor. All of the following are side effect of ritodrine except hypoglycemia, tachycardia, hypotension, tremor. Opioid के क्या क्या रिसेप्टर होते हैं? म्यू कापा डेल्टा. So either of the mu receptors or the kappa or delta, one is the opioid and non-opioid means any of the other receptors. So which is the drug that is active on the opioid and non-opioid? The answer will be either tramadol or tapentadol, because tapentadol is a noradrenaline reuptake inhibitor. So it should act on the both, either mu kappa delta or some additional receptor. So that is the question that the examiner has asked. Dr. Isra Mustafa. I hope all of you guys are aware that ritodine is a selective beta 2 agonist. So selective beta 2 of the skeletal muscle, if it is going to work at the skeletal muscle, they will be causing tremor. Selective beta 2 of the heart, because at the high dose they will be stimulating the heart as well, they can cause tachycardia. Okay? They will be acting on the blood vessel, and if they act on the blood vessel on the high dose, they can even cause fall in the blood pressure. So hypotension हो सकता है, tremor, tachycardia, hypotension is also a possibility. ठीक है? Now if the beta 2 of the liver will be stimulated, think, because liver is also having beta 2. Liver is also having beta 2. If the beta 2 of the liver will be stimulated, they will be causing gluconeogenesis, or other one is your glycogenolysis. Because of the gluconeogenesis and glycogenolysis, what will happen to the plasma glucose level? It will increase. So will it cause hypoglycemia or hyperglycemia? Any beta 2 agonist will be causing your hyperglycemia, not hypoglycemia. ठीक है? Because beta 2 of the liver will be causing gluconeogenesis and glycogenolysis. So what is the correct answer here? Examiner is asking side effect except. Undoubtedly tremor could be the most common side effect, उसमें कोई doubt नहीं है. Tachycardia, tremor, tachycardia are the common side effects. Okay, correct answer is A actually, which I don't think any one of you have marked. Beta agonist can also act on the high dose on the heart of the heart. They can cause tachycardia. If they are going to act at the blood vessel, they can cause hypertension as well. But hypoglycemia का reason, hypoglycemia नहीं होगा, hyperglycemia होगा. Reason I have explained, because beta 2 of the liver can cause gluconeogenesis and glycogenolysis. Last question for the day. To minimize the HPA axis suppression risk, what is the correct method of administration of prednisolone? So in this examination, we had around 30 questions. 2 questions were integrated with the medicine or allied subject, but 28 questions we could easily do from our pharmacology. The other 2 questions could also be done, which I have not included in our session. 28 questions only I have included. So for minimizing the HPA axis suppression risk, what is the correct method of administration of prednisolone? कैसे देंगे? All of you please try. Give at night just before the bedtime. Give on alternate days. Replace with the betamethasone. Divide in 3 doses and give small doses 8 hourly. All of you please try. This is the last question and then we will be done. Dr. Pooja is in favor of B. Dr. Anbu is in favor of A. Other students also please. Don't be hesitant in choosing your answer. Nobody judging you here. You're all here to learn. Go ahead, all of you. B or A. Okay. Now, we always try to give steroid in the night time. Due to chronopharmacological reason, steroids are highly effective in the night time. But to minimize the HPA axis suppression, what is the step that you will be choosing? First of all, I'll give you the correct answer. The correct answer is going to be alternate days. We have other ways as well, right? What are those ways, right? Apart from alternate ways, we have like pulse therapy. Okay? So exogenous steroid can always and always cause HPA axis suppression. To diminish this, the following step has been taken or will be taken. गुडमैन गिलमैन 13th एडिशन में तीनों के तीनों स्टेप के बारे में डिस्कस किया है. इंटरमीडिएट एक्शन प्रिपरेशन लीजिए, लाइक प्रेडनिसोलोन एंड इट शुड बी गिवन इन द मॉर्निंग एज ए सिंगल डोज, अगर इंटरमीडिएट एक्शन प्रिपरेशन लेते हैं तो. ठीक है. अल्टरनेट डे थेरापी विद द सेम ग्लूकोकॉर्टिकॉइड्स और पल्स थेरापी विद द हायर ग्लूकोकॉर्टिकॉइड डोजेस. राइट, पल्स थेरापी विद द हायर और higher dose than the physiological requirement. You will be giving intermittently. So by doing this one, you can reduce the side effects. So these are the three methods that has been explained in the book. Intermediate action preparation लीजिए, right? You are supposed to give in the morning. None of the option is having. They are having night before the bedtime. To reduce the action, we will be giving alternate days with the same glucocorticoid. Pulse therapy, always and always remember, pulse therapy if usually used if faster action is required with lesser side effect, lesser adverse effect or lesser ADR or lesser side effect. Okay. Pulse therapy. So these are the different questions which I wanted to discuss with all of you guys in our today's session of PYQ series 2022. In upcoming days, we will have one more session in which I will be discussing 2021 part 1 and 2021 part 2. So in that I will be discussing one paper of 2021, like let's say either June or December. We will be discussing that in upcoming days. I hope you guys enjoyed the session. I hope you guys learned something new. You were able to revise and you have already started the preparation, and these are the question that examiner is expecting. Even a simplest of the question, examiner is trying to give in a form of case. So always think about a case, a patient. Always think about a patient. A patient is going to present with this problem. What will you do? So you'll have to think like a physician. Then only you will be able to mark it very correctly. Okay. So thank you very much to all of you. If there are any query, you know where to ping me. You can write your query at any of the social media handle. Even you can write in Unacademy Telegram group as well. You can write and you can just tag it to me. As soon as I'll see, I'll try to reply to all of you guys. Okay. So with that, I'll take your leave. Any question you guys can ask now. If there are none, we are done for the day. Okay. Thank you very much to all of you. Have a good night.